Hi, everyone. Welcome back to the DBMI seminar. Today, we have another speaker in our special seminar series entitled Towards Diversity, Equity, and Inclusion in Informatics, Healthcare, and Society. Today's speaker is Dr. Irene Dankwa-Mullan. She is a nationally and internationally recognized physician and expert scientist working at the intersection of healthcare, health equity, public health, informatics, data science, and applied artificial intelligence, with over 60 peer-reviewed publications. She serves as the Chief Health Equity Officer and Deputy Chief Health Officer for Research and Valuation at IBM Watson Health. As Chief Health Equity Officer, she works across business market segments to promote a culture of equity, ethical AI, diversity, and inclusion. Her responsibilities as Deputy Chief Health Officer include leadership for evaluation research and implementation science, and promoting opportunities to advance the science of AI and advanced analytics. Dr. Dankwa-Mullan attended Barnard College, where she majored in biochemistry. She received her medical degree from Dartmouth Medical School and a master's degree in infectious disease epidemiology and biostatistics from the Yale School of Public Health and a joint MPH program. She completed her residency training in internal medicine at the Johns Hopkins Hospital's Bayview Medical Campus. Today, she'll be talking to us about the social determinants of health. And with that, I'll hand it off to our speaker. Thanks so much for being with us.
Thank you. Thank you so much for the invitation. It's really an honor to be here and so humbling that I get to speak in front of so many of you that are pursuing biomedical informatics. So really a pleasure. And I think this also has been open right to the public. So I'm happy to share some of the work that we're doing. Basically, this my disclosure that I am employed at IBM Watson Health and I have no other conflicts of interest. So in this session, I'll share some information about the availability of publicly available public data sets that capture social determinants of health, specifically various sources of federally funded data sets that include social determinants of health, and help you all understand the various dimensions that are captured. And I'll also share the initial phases of work that we're doing around leveraging social determinants of health data for our health equity research at IBM Watson Health, as well as introduce some of the informatics challenges when applying or leveraging social determinants of health data to relation for health services research. And then I will finally share a study that we conducted using machine learning and advanced analytics to understand the social demographic disease risk prevalence data that we thought may be associated with COVID-19 mortality across the United States. And to share how machine learning really can help capture these complex interactions of social determinants and health outcomes. So a little bit of background, the determinants that shape population health, as you know, include macro level conditions and policies, such as those social, economic, cultural, and environmental. The mid-level determinants such as working conditions and housing, and the more proximate determinants such as behavioral and those biological determinants. And these multiple determinants shape health, population health, and influence outcomes, all across the lifespan. They, however, have really complex and intricate relationships with patients' level of risk, patients' vulnerability, and health outcomes. And we know that they also interact along really complex and dynamic pathways to produce the health, disease progression, health outcomes and prevalence that we see at the population level. And in most instances, these exposures at the environmental or neighborhood level may have greater influence on population health than our individual vulnerabilities. Although we know that at the individual level, there are some personal characteristics, including a genetic predisposition that interact with the environment to produce disease. And so as a result, we know that there are limitations to our traditional epidemiology and statistical adjustment models in handling the computational complexities of multiple social, demographic, and environmental interactions involving the disease risk, involving disease progression, and the clinical outcomes that we observe, and that also leads to health disparities. Let's see. Next. We also know that place matters, right? Where we live can determine how well we live, and it's a significant factor of life expectancy. So the map that you see illustrates the range in life expectancy across counties in the United States. And it goes from 66 years in red to 87 in blue. And in some cases, the difference can exceed 20 years. You could do the same mapping for food insecurity, which is a risk factor for various health issues, including chronic disease, poverty, unemployment, and housing stability. We also know community, where you live, and social capital also matters and plays a role in how long and how well you live. And so some communities and neighborhoods, as you could see on the slide, like Chicago, Mississippi, Brooklyn, New York, all have higher rates of homicides, while other neighborhoods may have lower rates. And as you see on the top with Mississippi, having enough and the right type of food also impacts health. And so we all know food insecurity is a risk factor for various health issues as well, including chronic disease and poverty. And so really, place and geography is a real strong influence that contributes to our health. So unless a health system prioritizes addressing social determinants and makes efforts to pass data, EHR, administrative claims data that we work with, may not adequately capture those relevant social determinants of health data that really drive patient health risk, that drive disease progression and health outcomes. So it's really, really important to identify and enhance those data sources or our studies with the relevant social determinants of health measures, while also leveraging, the clinical data. So it's really, but I think it's also important to recognize the informatics challenges, some of which I'm going to actually describe in the next slide so that we could do something about it. And I put those in 3 separate categories, right? And these informatics challenges center around the data collection, the curation, and the choice of those predictor variables for the use cases in our analytics when we are trying to merge clinical data to understand its association with disease outcomes or predict outcomes. And so, for example, with data collection, we know that data collection and the fact that data is actually already disparate and inconsistent or largely incomplete. Social determinants of health screenings and assessments really vary across healthcare systems, across employers or organizations, and there is no standard requirement of how that is measured or required. In terms of curation, we also know that there are issues with the definition, the granularity, the content for social determinants of health data. And so, for example, a social determinants of health domain for economic instability, for example, may be looking at housing instability. And you may want to look at a diagnosis or an assessed needs that looks at homelessness. Homelessness can be whether it's unsheltered or sheltered, whether the person is in transitional or substandard housing. Does the person have a history of homelessness or at risk for eviction? And so is it based on rent? Are they behind on rent? Or the housing cost, they have housing cost strain and their rent is unaffordable. So all of this requires different kinds of intervention. And so depending on the granularity, if it's just housing instability or homelessness, we may not be able to really tell what sort of interventions are needed. There's also value in combining data, right, within the same domain, or create sort of aggregated data sets to assess social determinants of health. And so there are some agencies, such as, two examples are the Social Vulnerability Index or the Community Need Index. There's also an Area Deprivation Index that has been generated by CDC and other organizations. And so when these multi-component indices are utilized to develop maybe a range or characterize these, aggregate the data, it's usually helpful. And informaticists must look at ways to standardize these data so that it can be used in more reliable and valid ways. And then there's also the issue around coding and ontology mapping challenges. So in addition to having multiple terminologies of the LOINC and SNOMED codes, there are multiple codes that we can have within the same social determinants of health domain. And these can present challenges with the multiplicity and ambiguity of coding social determinants of health measures. And finally, I want, choices one, right? We know that there's value in adding social determinants of health data into our AI and machine learning predictive or risk models. But these models are more effective when there's readily available and complete social determinants of health data. So one that's diverse, one that's comprehensive. And so some of these are, these are some of the challenges in leveraging determinants of health data. But I did want to present a case. This is a study that we did, really trying to map COVID-19 mortality patterns. And in this study, we wanted to use machine learning to really understand the influence of population health demographics, social determinants on mortality from COVID-19. So we sought to really introduce predictive algorithmic modeling and machine learning approaches to the study, and really try to also understand those complex, the interaction of these complex multiple determinants of health at the population level. And so what we did was we then developed, there were several phases of this methodology that included identifying all the publicly available data and features for the study. So we tried to look at, population demographics, social determinants, health access, disease prevalence within geographies. We selected these variables that had only those that had complete data across all counties. And then we classified and selected the relevant variables. When I say relevant, those that had really strong associations with COVID mortality. And then we did some correlation analysis of these variables in county clusters. There was an algorithmic clustering process that was used by a data scientist to generate counties that had relatively similar geographic, sociodemographic, and health prevalence status. And then we did the final comparison with COVID-19 mortality. Just wanted to share for some of the variables that we use. So there was a range of demographic, social, economic, environmental, and disease risk prevalence that we know, can influence susceptibility to disease, and especially COVID and health outcomes. And these variables were retrieved, the data was retrieved from a wide range of data sources. So it included the US Census population estimates, the American Community Surveys with a 5-year estimates, small area income and poverty estimates. We used the Area Deprivation Index, the CDC's Social Vulnerability Index. Combine all of this for the study. And in terms of the COVID-19 related death counts, we retrieved it from the CDC's daily report from the beginning of the pandemic. And we looked at it through June, the month of June. And the reason was we really wanted to look at the accelerated phase of the pandemic before sort of any, when mitigation and lockdown was starting to be in place. And actually, this was when we also started the study, and we wanted to really track initial influence of social determinants. And we could have done this at any time. So this is the map, right, showing the county clusters. I would say that there were 34 variables that we initially selected, and 28 of the 34 variables were used as features for this algorithmic clustering. We did an analysis of variance, so an ANOVA-based feature selection really helped to identify the most variant features that impacted mortality out of the 28 variables. And so you could see the top 10 distinctive features that have been listed. And based on the 10 features, similarities, the clustering algorithms generated 6 optimal demographic and socioeconomically distinct county level clusters, as you could see, so across the US. In terms of description of the county clusters, so you could see here that the table describes the county clusters. So, or cluster 4, for example, had the most counties, right? Cluster 4, for example, had 356 counties, mostly in the Southern Black Belt. Bethel, the North Slope counties in Alaska. It included Pine Ridge, Rosebud reservations in South Dakota, as well as the Navajo Nation in New Mexico. And the key relevant features that were associated with mortality in this cluster included the unemployment rate, their social vulnerability index, residential segregation, preventable hospitalization rates, and so on. Cluster 5, for example, there were 223 counties that included New York, Queens, and Westchester County. And in this cluster, the prominent features really were the proportion that spoke another language or had preference for another language other than English. Black, Asian Americans, residential segregation. All those came up at the top. Preventable hospitalization rates and median household income, as you could see, as well as home ownership rate. So this is what we did. Cluster 4 and cluster 5 showed significantly higher COVID-19 mortality rates compared to other clusters. this is sort of a plot that compares the mortality across the county clusters. And again, I've listed, so it's no surprise, right? There were higher mortality rates among Blacks and Native Americans, as you could see, and those counties are highlighted in this plot. We were also able to illustrate the results in a ranked variable plot figure. So you could see there's several ways to present this. And in this figure, you could actually see, let's see, I think I can go back. Okay, good. In this figure, you're able to identify those key sociodemographic and related determinants in terms of their association strength and direction, whether positive or negative correlation with COVID-19 mortality rates. And so you could see population density, right, as well as the total population, as we know, is consistent across all clusters, showed positive correlation with mortality. However, when you look in county clusters 4, which includes the Southern Black Belt, the Black population density, HIV prevalence, unemployment rate were more significantly correlated to mortality compared with population density. This was another way to illustrate, again, with a heat map to show the associations and correlation. And again, each county cluster shows distinct associations with various demographic and social or health risk. So I do want to point out that, correlation is not really causation, right? Correlation merely quantifies the strength of a linear relationship between two variables. And so when you see a weak correlation or a lack of correlation to COVID-19 mortality, it does not necessarily mean that the selected factor was not related to the mortality rate, but instead there might be some non-linear relationship. And so we need to look, have a further investigation or research. And so factors that have these correlations, we really need to interpret it with caution. But this really tells that the influence of place, the uniqueness of place-based social determinants, population demographics on COVID-19 mortality. But I would say also that a limitation of the study was controlling, there may have been potential confounding factors. For example, age. We did look at that and integrate that in the classes. Morbidity is something that we also could not get across all the counties, and some unmeasured confounding variables that maybe could further influence correlation with COVID-19 mortality. But at least this is able to, point out some of the relationship with COVID-19 mortality and social determinants of health from COVID-19 mortality. So, in conclusion, I think this was shared with you this case study, which using the unique combination of machine learning methodology that is able to cluster counties by similar demographics, social determinants of health. We included HIV, disease prevalence, risk. The study really uncovers and highlights variation in the strength of different health determinants that are correlated with COVID-19 mortality across the US. And so, we are able to leverage these algorithms to capture these complex relationships. And, with more of the study, we can improve, and especially with more data, you can improve the predictive power and provide a lot of insights for public health and for decision making. And we know that, our traditional epidemiologic model is hypothesis driven or theory driven, whereas predictive modeling, machine learning is mostly data driven. So the more complete data, comprehensive data you get, the better the prediction is. And so emergence of machine learning and applied population health and its role, I think, should be at least recognized, right, to understand disease risk and especially COVID-19 mortality above and beyond what we're currently using. And so overall, I think these approaches might improve our understanding, at least, of social determinants and population health, and help to really inform policy, help to enhance tailored intervention. Also, one of the lessons learned, one thing to think about when you're looking at social determinants of health and data sources, we really need to be aware that there are differences in geographic granularities between data sets, different definitions, as I mentioned, the content. And we need to be careful about ascribing aggregate measures to specific individuals. We have to use aggregate data in the context of which we are studying. And really use care in terms of inference testing, and really be cognizant, aware of all the correlations that may occur in similar or related variables. I did, these are the references, and I'm happy to share additional information on, when the publicly available data sources and the links that we used. There are some really helpful resources that are out there for leveraging social determinants of health data sets. A good one also, I'm not sure if you heard about it, it's the Gravity Project, a consortium that is trying to really standardize social determinants of health measures, making it more granular so that it can be used by informaticists. There is a compendium of federal data sets that are addressing health disparities. There's a revised volume. I was involved in the earlier compendium. And so it has links to publicly available social determinants, but it includes a whole lot of valuable information around federal data sets addressing health disparities. And a few, for example, from the CDC, this data set directory of social determinants, and then a compendium. So that there are really a handful of these data sets. Within Watson Health, we of these publicly available in our own and Watson Health's data assets. And so within there's the market scan that has administrative claims. This may be a little dated, more than 245 million lives since 1995, and it includes, commercial claims data, Medicare data. We also have the Explorers, which is mostly EMR data. And we try and leverage others like, the weather company and EPA. There's a pulse survey that is also administered and has information on attitudes, behaviors, consumer preferences, their healthcare utilization. And we also leverage PRISM from Claritas to do segmentation and clustering. So, there are ongoing social determinants of health work that we're trying to leverage in our population health analytics using some of these data sets. I did want to acknowledge the ongoing, the two studies, but I know, these are, I'm working with very talented, a team that includes a team from actually Brigham and women, Vanderbilt, in the study, in actually the case study, the co-authors also were from Brigham and Women in Vanderbilt. And so just wanted to acknowledge that in my presentation. So thank you for your time and for listening. I planned on presenting for 30 minutes and wanted to leave, ample time for conversation, discussion, and Q&A. So thank you for your time.
Great, thank you so much, Dr. Dankwa-Mullan. This was wonderful, and would like to open it up for questions then from the group.
And I'm happy to, like I said, I think there is, for those of you that are involved in social determinants, population health, and the links, I'm happy to share sort of the database that we created for that as well. So it's sort of an easy access, and I can give you the resources and the links as well.
Oh, that's great, thank you. I do see one question in the chat from Maxine Rakoff. How do you determine income?
So good question. I mean, it depends. There's a range of, you could look at wage, you could look at, I think it depends on the research question that you have. So, some people look at wage and others would look at, not just wage, but also overall wealth and home ownership. But income is hard to, obtain in terms of publicly available data sets. And it always sort of proxy, based on, their employment or where they are. But I don't think with social determinants you could, so you sort of look at the economics in terms of employment and whether they have home ownership and whether, in what area they are. But I think that's definitely, in some you can really capture, there is, in the Department of Labor, they capture like unemployment or, rates of, they are, a region, and you basically have to look mostly by region and look at poverty rates and sort of map it. But there is no, and that's a good question. There is really capture income, individuals. So you sort of look at the population level and map it to sort of geography and where they are.
I have a question. Like I've done a little bit of work in, oh, by the way, thanks for a great presentation. It was really interesting. I've done a little bit of research in working with geospatial databases. And I was wondering how, you mentioned the problem with granularity when you're compiling a bunch of different data sources together. So how do you think about dealing with that when you're looking at data on the county level versus data on the precinct level, for example, or even more granular than that? How do you combine these kinds of varying granularities in the modeling? Because I assume that results in missingness and other issues when you're looking at this data.
Yeah, yes, absolutely. And it's really hard. That's why we captured it at the county level to, so that it was all standardized. But when we could conduct a similar analysis at the county level to look down at the zip code level. And that's a little bit hard or tough to get unless there's the data. Some regions and states are better at collecting social determinants and providing those, but and so there are some regions that have that granularity and that, you know, that kind of data, but it is a challenge, and I think that's where I had pointed out, for example, the Gravity Project, which is, you know, scholars and leaders in this field, and also, you know, interested researchers that are interested in really standardizing these data sets are working on so that they can pull all the data. But it is a challenge, and I don't think we have that. There's a long way to go with really looking at how we can leverage social determinants. I mean, we have to start with how we defining it, you know, and you know, ensuring, and also looking at, you know, even within the EHR system, the codes, you know, the line codes, the SNOMED codes, and ensuring that it's really capturing. For now, I think we're all doing a poor job at that, and there's a long way to go.
Great, thanks.
But hopefully we'll get there sometime.
Irene, this is Ted Shortliff.
Yes.
Hi, Irene. We were able to connect, even though I'm in a funny place right now. But I enjoyed the talk, and I have a question which is perhaps less about informatics and more about politics and policy, because it has to do with the extent to which the kinds of points you're making very cogently in your presentation are appreciated by key policymakers these days. I mean, I do see an awful lot written about problems with biasing in large data sets that are being used for machine learning applications, for example. You wonder whether that's sinking in and really to what extent, you know, health policymakers in the new administration at the state levels, as well as at the federal level, et cetera, are really taking to heart some of these points that are being made quite a bit in the literature. And yet
Yeah.
I just don't know what the sensitivity is out there.
Yeah, thanks. Good. So I'm actually hopeful. I mean, the administration has put out at least a few. There's an executive order and guidance. I mean, that is being the government now. I mean, there's one executive order, for example, that is looking at, you know, really identifying, doing an impact assessment, health equity impact assessment, to identify, you know, the impact of federally funded programs. And they've asked all the agencies to conduct these health equity assessments. You know, so what are the benefits federally funded in the communities that need the most? I think that we would all have to look at in our data sets, you know, have completeness and transparency in terms of race and ethnicity data, and in terms of geography. And I think this is all going to, it's definitely going to trickle down from the federal level down to the states, and you know, if it get, you know, CMS and healthcare, all of the partners to really look at our data sets. So I'm hopeful. I mean, there is a COVID-19 task force, right, that is with really good thought leaders and leaders in the field of health equity, including Marcella Nina-Smith, and they are looking closely at these social determinants and racial equity, and how that impacts health. I think, if anything, you know, I'm sort of hopeful that we need to change the ways we're doing things. We need to be more, you know, cognizant of really having complete data. I mean, we still have a long way to go, and I think this is where the informatics community and all of us working as data scientists and AI really need to think about transparency and integrate all of these data sets together. As you know, you saw, and we all know in some of the slides that are the clinical data only accounts for 20% or less, and there's behavioral, there's social determinants, and I think we are at a point where we can no longer just use clinical and limited data sets to inform our prediction, inform our risk, and just be complacent about it. I think that there's high visibility now, and so we need to do a better job. And that comes with looking at the data and how granular it is and how standardized it is and the definition. There is a lot of work to do. And so, yeah, I appreciate that comment and the statement about really now, it's more action now than words. I think you're right. It's been in the literature, and we haven't done much about it. And we now need to leverage our technology, our tools, and informatics.
Hi, Dr. Dankwa-Mullan. Hi, Reyes Nieva here. My focus is on leveraging health informatics to improve health equity. So very much interested in your work. The vast majority of people on this call today are trainees. And as part of our training and just career development, we're trying to decide kind of what path to take in terms of academia, industry, nonprofit work, government work. And your career has seemed to span the gamut. And so it would be great to hear some insight you might have as to like what was the impetus behind the transition from National Institute for Minority Health and Health Disparities to IBM Watson Health. And I'm very much encouraged to see that there are opportunities within industry to improve health equity. So thank you for a great talk today.
Yes, thank you. Wow, so I would, if you had asked me, 5 years, 10 years ago, in terms of my career, whether I'll end up doing what I am in industry and health equity, I would have said no way. So I think and especially now, I am really encouraged about industry looking at basically you don't have to just be in academia, but you can also have a career in industry. You can have a career in public health, and I've been really fortunate to after training in internal medicine, I was always interested in public health, and so that's why during medical school I also got my MPH, and initially I was interested in infectious disease. Because I wanted to, I born in Ghana, and came here for college. And so I thought about global health and tropical medicine. And there's no masters in tropical medicine that I could find in this. So that's why, I said, well, infectious disease is great. And so with this COVID pandemic, I think it sort of came in handy, even though I'm sure I had to get updated on infectious disease epidemiology. But I think right now, we always talk about how diverse teams can bring innovation. Multidisciplinary, transdisciplinary work is, I think, should be sort of our mantra. And so I shouldn't say I was surprised, right, to end up in industry and working with the clinician team, working with developers and designers on healthcare data or on artificial intelligence tool. So I think you could basically work anywhere. After my training, I worked in public health before I actually went to the NIH. So I think people are beginning to value, right, the multidisciplinary teams. I think we should be all open to that, where we don't have to work in our niches. And science, if we really want to advance the science, I think we need to all work together. We learn from each other. I've learned a lot. I'm working with a very talented team of bioinformatics ethnographers, and at IBM Watson Health. And I would actually mention that Dr. Ted Shortlift was really instrumental in building our team at IBM Watson Health. Had that foresight, insight to say, you need informaticists, you need to work with public health physicians like myself and scientists. And so thank you, Ted. I mean, sometimes you don't realize, you don't know what you don't know, is what I would say. So it's worked out pretty well, where, now there is a lot of innovation. There is, so think about teams, and possibilities of working anywhere with your background, informatics, bioinformatics, especially in the healthcare space. It's so much needed now. I mean, AI technologies, data is at the forefront of healthcare. We're going to go into a new normal with post-COVID, where everyone is needed on board to help advance the science. So it was, I would say, the reason the transition from IBM from NIH to IBM was happened was, while out at the NIH, maybe my final 2 years was the launch of the precision medicine and big data. And we were working during that time, President Obama had unveiled the Precision Medicine Initiative, and it was quite an exciting time for science. And we at NI, the Institute of Minority Health Disparities, wanted to ensure that, it doesn't exacerbate existing disparities, and that we could use precision medicine to really advance health disparity science and big data. And so, that was, we were all involved in that, looking for, academic researchers that could help. But the opportunity came within Watson Health to, where to really use, be at the forefront in industry, under the leadership of Dr. Curie, who said, we need evaluation, we need to figure out how we can work with data and AI. And so, thinking about, again, transdisciplinary team, I took that opportunity to join IBM Watson Health. And then since then, I've been here, and it's actually 5 years in May.
Hi, Dr. Dankwa-Mullan. This is Adrienne Pichon. Again, thanks so much for sharing your work, and also your perspective about, as a trainee, what can we look forward to after this? And, I think multidisciplinary work, that's so encouraging. That's really, I think, important for me. And so knowing that there are jobs where there can be teams made up of different kinds of people and thinkers and scientists and clinicians, it's really cool. My question has to do with population level inferences versus like person level interventions, and also like precision medicine, and like how we protect individuals who like are made vulnerable by these structural forces. So like these data are like important for identifying and measuring and characterizing health disparities, but then also could reproduce or exacerbate some of the same problems that we see being made more visible, hyper visible, even the disparities in how these data are measured among different subpopulations, and particularly that they're poorly measured among vulnerable populations. And so, it's so important that we pay attention to these data and include these data and curate these data. And, if we're going to be inferring these data, either from unstructured clinical text or from other things in the clinical chart that might be important for some purposes, but then, if we're doing that research, considering the context and how we apply it and how we use it, but then kind of as the field more broadly, how do we make sure that our work is not contributing to harms that are reproducing these disparities as we try to improve, try to make, yeah, I'll leave it at that.
Yeah, no, you're making great points, really important and really critical points there. I think it mattered so much in terms of ethics, ethical AI, and ethical data. I mean, because one of the things that we all are aware of is how AI and data can really harm, especially communities that are already being marginalized, already being excluded, and already being harmed. And so at the top of all that we're doing, I think part of this, when I talk about multidisciplinary teams, especially with informatics, with AI, needs to center ethics. And when you're centering ethics, ethical AI, you also need to look at racial equity, social justice as your outcome. So it's not enough to say, oh, I'm testing this predictive model to make sure that it is, the power is, you also have to look at the outcome that, will this prediction or this model lead to outcomes that are advanced racial equity, advanced social justice, and is ethical, and I'm actually benefiting the community, everyone, not just a select few. So you're right. I think it's so important. And that's one of the things that, I'm advocating for, not just across IBM, but all across technology and our, even in academia. When I've looked at data sets, for example, or predictive analytics, and I'm reading, they receive our operating curve was, and looking at all the prediction and the accuracy, I'm looking more at the outcomes, and so what happened in the end. And I think we need to include that, and really have like a framework that ensures that we are not harming. One of the things that I think we also want to advocate for is, as part of the teams, engaging the communities. There's a lot to learn in this space, and actually you've made all these great points. We do have a lot to learn, and with humility and acknowledge the fact that AI can do harm, and we need to be inclusive, we need to be transparent, and work towards that goal. But thank you.
Great. Any final questions?
I just wanted to say thank you so much again for this talk and for this conversation. It's been really interesting and important, I think, to listen to. I wanted to ask a little bit about, as a follow-up to Adrian's question about that last point about, I was curious to hear your thoughts. I think in general, there's a lot more awareness about biased algorithms and biased AI. There's a lot more focus on this, but I think one of the things that we're still trying to figure out how to do, especially when it comes to health informatics and a lot of the sensitive information, is how to give the information back to people in ways that are empowering and helpful and useful to communities, especially as we start to discover it in the beginning ourselves. How do we disseminate that information back to communities where the action can really take place? And especially in dealing with these public health challenges, I know that's something that public health as a field has been dealing with for a while. But I was curious if you had any thoughts, especially given the current pandemic, amid all of these other political conversations, if you had any thoughts on how that could be disseminated and how that might be different between academia, industry, or other places. I was just curious for your reflections on that.
Yeah, I would say that we really need to change the ways in which our science is conducted, in which our science is reviewed at the NIH. They're doing that, in which our science is disseminated, where we feel that only publications in journals, high impact journals, need evidence. I think there's a whole lot of work that we need to do and changing that, right? And I think, and you asked a good question, disseminating it back to the community. I think that working with teams or health communications to disseminate that information back in a way that the community will understand. And I think that is so much needed and so much, but it's not even, the people, I really sort of take my hats off to those that do it, the teams that work with communities and are able to really, present, and sometimes it's leaders or thought leaders in that community that disseminate the information back. But you're right, there needs to be a way in which we really appreciate different dissemination channels, whether it's through, trainings or developing literacy, low literacy materials so that they understand, or engaging them in the process to say, this is the study we're doing and this is your data, and not, the data does not belong to, the developers or something. But I think there's a lot of work to be done, and I don't know the specifics in terms of how do we disseminate into the community, except to engage them in the process and work towards sort of a participatory research where the phases, development, implementation, dissemination into those channels that they are comfortable, into the language, right, that they are also comfortable with and understanding. So a lot of work to be done. And so those are all great questions.
Thank you so much. Oh, it's really helpful and exciting time for all of us trying to move things forward here.
Absolutely, I agree.
Great, thank you. I think we have, just 1 or 2 more minutes. I see a comment in the chat from Shreyas. I don't know if he wants to chime in there or if there is another question from anyone. But go ahead, Shreyas.
Yeah, I was going to let anyone ask their last questions, but my comment was basically just that I think your point about looking at outcomes really resonated with me, because a lot of times, even in my own research work, I always kind of get boxed into looking at maximizing predictive modeling metrics. And I think it's always important to go back and question the problem itself, the outcomes, as well as the data you're looking at. And I think that's good to keep in mind as we're working on a different set of problems in general. So yeah, thanks for that insight.
Yeah. Great.
Great. Well, with that, I think, well, thank you so much, Dr. Dankwa-Mullan, for an excellent presentation and excellent discussion as well. We really appreciate your time and presenting for our special seminar series. So thank you.
Thank you so much for inviting me. It's really humbling and honored to be here. So thank you.
Thank you so much.